This is Amber Rogers, and I work for Mountain Pacific Quality Health. You guys are definitely in for a great treat today. I've actually seen this presentation with Tamara Knotts and Gina Pate Terry, and it is absolutely fabulous. So I'll just do a quick introduction of them, and then we'll go ahead and get started. So Tamara Knotts is, she received her bachelor's in education from Western Washington, and then her master's degree in social work from the University of Washington. She holds both degrees, or both licenses as a licensed clinical social worker, as well as a licensed addiction counselor, and has a broad experience of working with clients in the substance use and mental health fields. Everything from direct service providers to the administrator of programs and services from a wide variety of clientele. Currently, she's the director of the Integrated Behavioral Health with Montana Primary Care Association. Gina also works at the Primary Care Association and has over 20 years of experience in working in the fields of mental health and addiction. She is a graduate of Montana Tech Liberal Studies program and received their Montana Tech Outstanding Alumni, which is awesome. Her master's degree in social work was from the Walla Walla College, and she is also duly licensed. Her experience ranges also across many fields, everything from working in the chemical dependency services at the Butte-Silver Bowl County, as well as an adjunct professor, private practice, and consultant at the Southwest Montana Community Health Center. And like I said, she is also currently employed by Montana Primary Care Association. So because everybody always asks this, when you, because you've registered for this, you will receive a copy of the recording as well as our slide deck. So feel free to look for other opportunities to attend other webinars of ours. Mountain Pacific, we are currently a subcontractor from a HRSA grant, doing training in the addiction and prevention, treatment, and recovery efforts across the Highline of Montana. And that's where this project is funded from. So we have no other disclosures to make. So next slide. And I'll let Tamara take the ball.
Hi, thank you so much, Amber, and excuse me, Gina and I are really happy to be here. We do adore, for lack of a better word, this presentation on language and stigma. Certainly is something that I think the fields of both mental health and substance use disorder have been aware of and kind of taking on for a long time. Gina and I, gosh, we probably have shared 75 years of experience in the field and really have had an opportunity to see how things have developed and not developed in the world of language and stigma, specifically when it comes to substance use disorders and the patients that carry those diagnoses. So we are really happy to be here, honored that Amber asked us, and we really hope that you enjoy our information today. So Zoom tips and tricks, I think we all have this down by now. So I'm not going to belabor this. You know your audio, you know your video. And I do want to encourage everyone to ask questions. I'm going to keep an eye on the chat box as we move through our presentation today. Gina actually will be doing the bulk of the presentation, but I am going to keep an eye on that chat box. Feel free to ask questions at any time or make comments, and I will very politely interrupt Gina and share that information. Then a little bit about MPCA. We are the Montana Primary Care Association. Our mission is to promote integrated primary health care to achieve health and well-being for Montana's most vulnerable populations. So how that translates into the IBH department, which is comprised of myself and Gina and 4 other team members, is we work very diligently, not only with our federally qualified healthcare centers, but we also work with tribal organizations, rural access hospitals, SUD agencies, mental health agencies on integrating care and really facilitating team-based, team approach care to make everyone an integrated system, because we know it works and we know the outcomes are better, not only for the patients, but for the staff. We're also highly involved with medication-assisted treatment and bringing training and assistance for program implementation to any kind of an environment in Montana. So we're busy. We are very busy. So I'm going to turn this over to Gina. She and I are going to tag team things. You guys are going to get to have a couple of videos today, which is always so incredibly fun. And Gina and I have known each other for many years, and we've worked together as partners in IBH crime, we like to say, for the last 2 years, and have done a lot of training and just really appreciate audiences and audience participation. So Gina, I'm going to turn this over to you.
All right, thank you. And just ditto to everything that Tamara said. We are so very grateful to be here today. And I love how they both talked about all these years of experience that we've had. And so when people ask me, sometimes people will ask me, you know, how many years have you been working in the field of addiction? And I usually say since birth. And I'm laughing, but I don't guess it's that funny, but the truth is, I feel like I've been working at it since birth. My father came home from a war and came home with PTSD, although back then we did not call it PTSD. I think they still called it shell shock or something. And he found there was no treatments because no one even talked about it. And he found a treatment that worked for him, and that was alcohol. And it did. It helped him with the flashbacks and the signs and symptoms of PTSD. And then it turned on him and it killed him. So, and I share this story with you today because I suspect that everyone that is on this call today has either a family member or a friend or an acquaintance who suffers from this illness. And so today, what I would like for you to do, if you'll just indulge me, is either write their first name down somewhere, or you could whisper or say their first name aloud. You could put it in the chat box, just the first name if you feel like it. But let's do that just to bring their spirit in with us today, to spend this time with us while we're together today. Let's just take a moment. Because we all know someone. Thank you. All right. All right. So we'll get on with it. Tamara, let's imagine. All right. So indulging me again, I am going to ask you, I'm going to ask your permission using my motivational interviewing skills. So I'm going to ask your permission that we just do a little activity together. So I'm going to ask you to just take a minute and just ground yourself, close your eyes, and take a nice deep breath. And then just imagine a whiteboard. So you've just got just a blank board. And then I am going to say a word. And when I say the word, I want you to notice the first thing that pops in your mind. I'm going to count down from 3, and then I'm going to say a word. Okay, ready? 3, 2, 1, alcoholic. Just the first image that comes to your mind. All right, now take your eraser and just clean that whiteboard off. All right, so you got a nice clean whiteboard again. All right. Nice and blank. Ready? 3, 2, 1. Drug addict. Okay, just the first thing that comes to mind. All right, thank you. So this is kind of an old exercise, but it's a lot of fun. So typically when someone says alcoholic, the first thing that comes to mind is an image of a man. All right, usually the man is white. Usually the man is old. And usually the man is dressed in some clothes. It looks like he may have been living on the street or is really having a hard time in life and down and out. Typically, when we say the words drug addict, again, the first thing that people typically see is, again, a man. It's usually a younger man. Typically, they will have brown or black skin. And they look like they're dressed fairly well. So I don't know if you guys know how to raise your hand or you can put it in the chat, but is that image maybe what you saw? So let's go to the next slide. All right. So I suspect for those of us who wrote someone's name down, and I see in the chat that some people shared, thank you so much. But for those of us who were able to whisper someone's name that we care and love about, they probably did not look like this, right? And they didn't look like this because this is a stereotype. All right, let's go to there's a definition on the next slide of stereotype. So it's a widely held but fixed and oversimplified image or idea. And the bad thing is that it can lead to bias. All right, and so that's what we're going to be talking about today is some of these biases. And then on the next slide, Tamara, I believe we have to like click about 5 times here. Thank you. Oh, there we go. So here are really what we're talking about the most today is explicit bias and implicit bias. Okay, they're both, neither one of them are good. The explicit bias is out there, okay? So people who have explicit bias towards people with substance use disorder are conscious of it. They know it. They talk about it. They're not ashamed of it at all. And it was learned. So you might have an Uncle George who says, those meth heads down at the convenience store, somebody needs to pick them up, put them in the back of a pickup truck and throw them off the pier, right? Okay, so that's explicit bias. It's right out there. You can see it, and now you can name it. Implicit bias is what we want to talk about, and it is unconscious, all right? So after today, you will be conscious of it. I am conscious of my implicit bias now, and I still catch it. But that's what we want to do that with the implicit bias. And that's why we're having these trainings, is so that when implicit bias raises its ugly head, we can do something about it, okay? We can shut it down. We can be kind to ourselves and go, ooh, there that was. But it's unconscious and we have nothing to do with it. Yeah, I mean, it's just, we just picked it up from television, from the movies, from the people who has the explicit bias. So even though it's not conscious, it is what causes us to, if we're walking by the people standing at the convenience store who look like they're struggling and they're sick with this illness, it's what causes us to hold our purse or grab our keys. And it's not a conscious thought. It's like, oh, they look like they're scary. It's just, it's there. So we have nothing to do with it. doesn't mean we still can't believe and be a social worker and be in this field and care about people and even love them, but it still is still there, and it's dangerous. It's dangerous. The confirmation bias is we find ways to, nobody can change our mind, right? If you, like with that explicit bias, you know, you're pretty conscious of it. And with confirmation bias, nobody's going to be able to tell you, no matter how much research, this class probably wouldn't make a huge dent. But the reason the implicit bias is so dangerous is because it leads to discrimination. And so with discrimination, people don't get treatment, right? People, because if we are struggling, if we are discriminating against people, we don't maybe believe they have an illness, right? So maybe we know that this person would benefit. So withholding medication is another thing that can happen with discrimination. So maybe we have somebody who's coming in and we know that they would benefit from buprenorphine treatment, and we don't think they deserve that treatment because we think it's their fault that they're that way. So withholding medication, withholding treatment. If you've worked in healthcare, you've seen this, right? Withholding housing. There are people who are struggling with homelessness that because of their illness are not able to find a place to sleep. Their ability to get a job. And pretty amazingly, I think physicians and nurses struggle with this a lot. Once they have had this diagnosis, oftentimes they will not be able to get a job. The ability to get insurance or to have insurance pay for treatment. I've certainly experienced this in my practice, where I would be treating somebody for this illness and their insurance would not pay for it. So we're just going to go on to the next one and talk a little bit about how did we get here? How did we get here? So this is just a brief history, starting with the 1800s. Now, the history of substance use goes back about 5,000 years, and I'm not exaggerating, but we're just looking at the United States. So in the 1800s, it was treated much like other behavioral problems or mental illness, is people were put in special asylums for the inebriates. And then let's just go on to the next one. So in the 1900s, there were states that were calling for mandatory sterilization of people who had the illness. This isn't that long ago. I mean, if you think about it. So we started the first prison. So we started putting people in prison for having this illness in 1935. And then in 1939, the big book was written. The big book, Alcoholics Anonymous, was published, and we saw a lot of things change. A lot of things started getting better. The AMA started defining it as an illness and the hospital administration started recognizing it as legitimate and urging people to give people that were struggling with the illness admission to hospitals and trying to prevent discrimination. So things were going fairly well, especially in the 1960s. Insurance companies started reimbursing for treatment. And then we did the war on drugs in the 1980s. So has anybody seen the movie The Anonymous People? If you haven't seen it, I would just say jot that down. It is a must-see, and I believe it might be on Prime. But in that movie, they interview people talking about this period of time. And one of the people they're interviewing says, "We could not build prisons fast enough." So people who were suffering and struggling were not getting treatment. They were being punished because there was that core belief that they deserve it, that they should be able to control it, and that it was a moral rather than a medical issue. And so as a result of reimbursement by insurance companies, they stopped reimbursing for treatment, because why would they? Because people were going to prison instead of treatment. So we had to deal with that for a while. And then in 2002, buprenorphine came in for clinical use. And even though a lot of people did not benefit or did not get a prescription for it, it kind of legitimized the illness as an illness because there was a medicine for it. And the big one was the Affordable Care Act. I mean, the Affordable Care Act was huge. It was written into law that substance use disorder were essential to healthcare services. So on the next page, I just threw together some pictures. Tamara and I just kind of threw together some pictures of people that we've lost to this illness. And these aren't counting the ones. I could fill this page up working in the field. So many of my patients haven't made it. So, all right, so where do we go from here? So here we are. Finding ways of reducing harm to the individual who's using substance and respecting their human rights. And that's what we are focusing on today, is respecting their human rights. And respecting human rights means reducing stigma. So on the next page, there is a, excuse me, there is a definition. Oh, it's not a definition, but it is a statement that stigma is the primary persistent barrier to high quality integrated substance use disorder services. And persistent barrier, excuse me. All right, let's go to the next page and hopefully I can talk. All right, it's because of stigma that some people do not seek out treatment. Why would you? And there is so much research on this, you guys. I mean, once you have experienced the stigma, and I don't know if any of you from Montana have ever heard Jason DeShaw perform. He is a singing cowboy here in Montana. And in one of his songs, he sings about going into the emergency department. And he's so sick and wants to die. He just can't take the pain any longer. And he talks about the way, the look in the eyes of the staff and how they condemn him and judge him. And he's an amazing, amazing young man. But he never wanted to go back. And I'm sure those of you who work in the field have had patients who will say, you know, even though you know they need to go to the emergency department because, you know, they may die from this illness, they won't go because they do not want to be disrespected again, that feeling of being shunned and judged. And then it's because of stigma that some doctors will not treat people with substance use disorders. And then this is a big one. So the pharmaceutical companies won't work toward developing new treatments for individuals. This is all from NIDA. And so there's new medicines that come out all the time for most chronic illnesses, but I think Suboxone was the last one, and that was 18 years ago. So we got to start caring about each other. All right, so we're going to talk about the different kinds of stigma. And so self-stigma is by far probably the most malignant of them all. And it is about the guilt and the shame that the person with a substance use disorder has about the ways that they might have harmed themselves or others. And it's debilitating, and it leads to not getting better. And really, it's that they have bought into that belief that it's their fault, that they should be able to control this. And somehow they are weak and unworthy. So that's self-stigma. The other one comes from us. It comes from healthcare providers. And okay. So they view their patients differently. So patients with a substance use disorder, they have lower expectations that they're going to get well. So right away, you know, they don't have a chance. And it's for the same reason as for this with the self-stigma. It's about perceived control. They should be able to control this, and perceived fault. Somehow it's their fault that they're in here today, struggling and suffering. They just should quit, right? Yeah. So it happens in treatment centers, it happens in hospitals, it happens in clinics. It is everywhere. All right, and then the family stigma. So I was just really blessed at one point in time to see David Schiff. He spoke at a conference that I was at, and I don't know if any of you have seen this movie, Beautiful Boy, but he tells his story as a father and their journey through his son's drug addiction. And he talks about how as a family, as a parent, he was shamed and blamed that somehow it's the parent's fault that the child has the illness. And we don't do this with other illnesses, other chronic illnesses. So what he was talking about was comparing it to cancer. And if a parent has, when we have a child who is in treatment for cancer and they complete their round of therapies that they get at the cancer treatment center, when they are left, there's balloons and well wishes, and they're set for the rest of their life to get follow-ups, to manage their symptoms, and make sure that that cancer does not come back. And yet at a treatment center, typically in the past, I'm thinking it's better now, they would be out the door and say, you know, go to 90 meetings in 90 days, get a sponsor, never talk about see your medical provider, never that follow-up as a medical illness. So it's a great movie. I would watch it if you get a chance. I'm recommending all these movies today, but that's good for COVID times, right? So I love this picture, and I think about this little boy because of the family stigma. And I think about for the rest of his life, he will remember what it feels like to be stigmatized he will remember what it looks like when people are staring and judging whichever member of the family is afflicted, and they know. And it'll affect the rest of his life, if he maybe is able to have a trusting and open relationship with people. So, but patients who experience and expect stigma are less likely to seek or access services, and they drop out of treatment early. So that goes along with what we were talking about with Jason. All right, we're getting there. I think we have a video now that we're going to show.
We do. We have a video. It is called The Stigma of Addiction. It's actually a public service announcement. So let's take a look at that.
Yeah.
But
Let's
struggle
start
with
that
addiction.
over.
We all have our own issues. Some people struggle with ADHD, some people struggle with diabetes, but I struggle with addiction. I was at a party when my friends told me to try it. They said it was okay because everyone else was doing it. And so I did. I tried it, and I became hooked. I was only 16 when I lost my friends, my family, and everything I had ever loved. I needed help. I needed support. I needed somebody to tell me that they believed in me, that I could recover. But instead, they called me names like junkie, thief, bum, and loser. It wasn't about the lack of money for therapy. It was about the lack of faith that I had in myself, the lack of faith that was constantly reaffirmed by the people I loved most. The guilt, shame, and isolation made it nearly impossible for me to ask for help. But one supportive friend, and 5 years later, I stand here to tell you, words are more powerful than the substances that we are addicted to.
When used incorrectly, they can set you on a path of indestruction.
But when used correctly, words have the power to heal, nourish, and mold individuals.
If you know someone who is struggling, please seek help.
But most importantly, believe in yourself and believe in your loved ones.
Thank you, Tamara. That's so great. That's so great. And it just leads us into getting to the nitty-gritty of this, is how powerful the words are, right? Because when she was talking about, you know, junkie, loser, addict, I mean, that's name calling, right? That's bullying. That's name calling and bullying. And our culture has told us that it's okay to do this. And so, you know, being able to change. Yes, yes, Amber, great. So words have power. Words have power. Before you guys came on, Amber and Tamara and Mary and I were talking about the power of words is the power of our thoughts and our beliefs, and the fact that the chair we're sitting in was a thought, and somebody had to come up with a word to make it a chair. So they really are powerful. So what we want to learn to use is non-stigmatizing language and person-centered in our person-centered care that we provide. So there's a quote from Otto Wall, and Otto Wall, I do not believe he is still alive, but he did so much work with mental illness and words. And he said, words have power. And they have the power to teach, right? They have the power to wound. Most of us have probably been wounded from words before. And this is the scary part. They have the power to shape the way people think, feel, and act towards one another. So our words are really important, and language matters. On the next one, I just love this quote. It is unknown who wrote it. So if we want to nurture something, we call it a flower. If we want to kill something, we call it a weed. Don't you just think that is powerful? So, and I chose the dandelions. I'll just tell you guys a little bit about. So I chose the dandelion because my mother-in-law lived in New Hampshire, where dandelions, they ate dandelion greens and made wine and things. And so she came to Montana to visit us, and she looked at my yard, and there were a lot of dandelions, and she was going, oh, look at the beautiful dandelions. She was so excited, and I wanted to kill them because to me they were a weed, and to her they were something that was nurturing. It was flowers that were and plants that were nurturing. So I think that's important. What we call something, what we say is important. So there's all kinds of studies and research, you guys. And just recently, this is the latest research, Tamara had found it and sent it to me. So let's look at this. So these are It's a study by Recovery Research Institute. And so it compared how people would feel determined on what words they used. And so the words they were using was a substance abuser versus person with a substance use disorder. All right. And so 50% of the participants were in healthcare. 20% of the students were students, 29% were outside of healthcare. Some of them didn't list anything. A lot, mostly white, female, and educated. So if you can look down here, so if you decided if they were substance abuser, only 41% thought that they needed treatment. 69% thought that people that were had a substance use disorder needed treatment. 67% thought people needed to be punished if they were substance abusers, compared to 23% of people with a substance use disorder needed punishment. They were considered a social threat if they were abusers, compared to the others. So that is that. So let's go on to the next one. And I'm looking at my time. Oh, we're doing great. Okay, so here are the words that we're going to look at today. So in our video, the lady was talking about addicts. So these are words we want to avoid: addict, alcoholic, junkie, abuser. What are some of the other words that the other things that we call people? If you can just put that in the chat box. What are some of the other names we call people? Remember, this is name calling. This is bullying. Drunk, loser, yes. Thank you, Amber. Any others? Druggies, drug seekers. Once a junkie, always a junkie. Those people, right? Excellent, excellent. Losers, Burnouts. None of these are nice, very nice, are they? All right, okay. So the problems with these are demeaning terms, all right? Okay, and so it means the person is labeled by their illness, right? And it can imply that there's no hope. I mean, if they're a junkie, if they're a loser, yeah, there's no, I mean, that's just who they are, right? But if they are a person with a substance use disorder, a person with an alcohol use disorder, a person with an opioid use disorder, there's some hope in that, isn't there? There's some hope in that, where that name calling just puts them in a box. Then there's no way out. All right, remember the guy with the self-stigma, or Jason, my friend Jason, when he went to the hospital, he went in as a loser. You know, nobody was looking at him as a young man with an alcohol use disorder. All right, so that's what we want to do. So if you, and the thing about this whole training is, please do not get down on yourself if you make a mistake. You know, I mean, if this is, especially like one of the things is alcoholic, you know, because back in the day, alcoholics, saying somebody was an alcoholic was fine. And in a 12-step meeting, and we'll talk about that later, in a 12-step meeting, that's fine. And if I have an alcohol use disorder and I want to call myself an alcoholic, that's fine. But as a professional, we want to say it's a person with an alcohol use disorder. So the other one, yes.
Oh, go. I was just, I am going on here and making it so everyone can talk. So I'm unmuting everyone. Okay. And I know we've got a video coming up, but I did just want to let you know that in case we want to do some discussion and out loud questions.
Mhm.
Okay.
Love it. Love it. Please just interrupt if you feel that burning desire, for sure. So another one that we're looking at is clean, the use of clean when we're referring to recovery, right? So I could be sitting with a patient and I could go, so I see here that you've been clean for the past 5 years. All right, so what's wrong with that? So what's the opposite of clean? Right? Yeah, so you've been clean, but we all know you were really dirty before, right? Yeah, so that implies that when they were symptomatic, they weren't symptomatic, they were dirty. There was something wrong, right? Because we all know how you get dirty. So doing that one. So the problem with the term, it implies that when the person was in their active addiction, they were dirty, unclean, unwanted, stigmatized. So we're stigmatizing them and pushing them away because we don't want dirty, unclean people around us. And they know that. And if we think they're dirty, they know they don't want me here. I am not welcome. I am dirty, and they know it. So instead, we use remission because that's a medical term. The signs and symptoms of their illness have disappeared. Yeah, I like in remission, free from substance use. And even if they say it, and I just practice this, you guys, you can just practice this. And if they say, you know, I am clean for 30 days, you're like, oh, that's so great. So no symptoms in 30 days. Right? So they really understand that we're talking about that. The other one is when we're talking about their urine screens, calling urine screens dirty. We don't do that with any other, like a person with diabetes doesn't come in and we don't say that their urine is dirty. We say that their urine has high sugar. And so what we would want to say instead, so we're going to treat the urine of the individual with a substance use disorder in the same way that we would treat any other chronic illness. And so we would say that their urine screen is positive for opioids today. Some people will say there was an unexpected urine screen and just leave out which substance was in there. We're also getting away from saying drug overdose. And these are going to be hard. I'm going to tell you, it's just, it's just habit, and it's that implicit bias. It's not because we don't care. It's not because that we think they're bad. It's because it's what that's what we've done. Okay. And so, so with the drug overdose, the problem implies that they caused it. So instead we're using drug poisoning. We don't say alcohol overdose, we say alcohol poisoning. And again, the CDC reports that 86% of drug poisoning deaths are unintentional. There's 8% maybe suicides. But it is not, the drug overdose implies that they did it and it's their fault and we blame them, and we don't. And relapse, this was a really hard one, I think, and is for everybody, but we do not use relapse in any other situation. It kind of has an implication that there's some kind of a moral failing. So using it, so we are trying to use reoccurrence or a return to use instead of relapsing, which is, I think it's like a religious. So anything on this? So how do you guys feel about this? The other ones that I want to just kind of talk about a little bit is, and I got called on this the first time I ever did this presentation, which was years ago. And I said, if we want our patients to be honest with us, and then I had somebody raise their hand in the audience. And so she said, you know, when you say honest, it implies what? That we're lying, right? That we would be lying. And so instead, if you can change that one, I hope we can put this on this slide, instead of saying honest, say accurate. You know, patient appeared to give accurate information instead of patient appeared to be honest.
Great point, Gina.
Yeah, yeah.
You know, the other thing that occurs to me too, and it relates to a training that we've done in the past about substance use disorders as a chronic illness. And a lot of our language and stigma comes from a couple of places. It comes from how we've been enculturated and how, you know, our general cultural, general public, our medical field talks about substance use disorders. And it also comes from what our beliefs are. And oftentimes, you know, we have found that believing or understanding that substance use disorders, just like mental health disorders, are chronic illnesses that require lifelong management kind of takes a perspective shift on our parts. You know, we all have our own internalized biases that need to be worked on too. So just wanted to bring that up before we head into the video, but also did want to invite anyone with questions, comments, just unmute yourself and see if you can get that out there.
So I kind of have a question for you guys. This is Amber. You know, I've often heard that it's a chronic and reoccurring condition. Substance use disorder is that when you're introducing that to patients, is that something that is kind of off-putting? Like, you're saying that I'm going to fail at this if you call it a chronic and reoccurring condition?
You know, what I like to use, Amber, is there are some graphs that show the rates of reoccurrence with chronic illnesses, and it's got diabetes, hypertension. What else is on there, Tamara? Asthma. But anyway, it shows like when people are diagnosed and then how often they have a reoccurrence, and substance use is in there as well. And it's the same with other chronic illnesses. So the rate of reoccurrence is similar. So I think what Tamara was talking about, just keeping talking about that this is a chronic illness like other chronic illnesses, just normalizing that. And with hypertension, you know, sometimes symptoms return. And when they do, we change the treatment, we get on it, you know. Does that help? What do you?
In fact, you know, SUD has better outcomes than hypertension at this point. Yeah. And it's, you know, when you think about a relapsing illness too, it's, you know, using those words can kind of give permission, you know, inherent permission to, oh, well, I can just keep using substances compared to, you know, there may be a few setbacks and and that's fine. We'll work with that and just kind of get right back up and on the path, on the journey again.
Yeah. I think I would not say that is in the present, you know, knowing what I know now, because we don't, when we talk to people about diabetes, we don't say this is a chronic relapsing disease, although it is. And we don't say it about hypertension, although it is. We only say it about that. And I think as with a lot of these things, it's good intentions, you know, that somebody probably had really good intentions of letting them know that it's the natural progression. I think talking about, you know, watching for signs and symptoms of the illness, just like you would with diabetes or hypertension, you know, here are the symptoms, you know, want to watch for them, be prepared what do I do? If I especially talk about cravings as a symptom.
Mhm.
So I have another question too. So,
Sure.
and just again, this is a very assumption loaded question, but I think that the emergency departments often face the largest encounter with patients um, are that are there because of their original substance use disorder.
Mhm.
And when you're trying to police your own language, that's admirable. But how can people help plant the seed with folks that perhaps chronically use stigmatizing language? What are some ways that we can help each other be better and more receptive?
Mhm. That's a really great question. And one thing that can be effective is if someone makes a statement to you and it's filled with that stigmatizing language, is just to paraphrase and repeat the statement back to them using using better language, using their preferred language. So just um, modeling what to say.
Amber, this is Leah. Hi.
Right.
Another thing too, like we all, have implicit bias, and I think that sometimes it comes out, even if all of these things, it still can come out sometimes. So if you're saying, like, oh, I'm so addicted to this, right? Like, and then catching yourself and then saying, that's not the kind of language that I want to use. So just like also demonstrating, how you can change your own language.
Mhm.
Humility.
So like correcting yourself, Leah. So you just,
Right.
So instead of saying I'm a chocolate addict, I'm going to say sometimes I eat more chocolate than I need to. Or
Right.
yeah, that's great. Exactly. So and I love what Leah's saying, because if you catch yourself and you're going to slip. My hardest one was clean, because when I grew up in the field of addiction, that was the greatest compliment you could give somebody, is tell them, oh, so you're clean. And so I would slip all the time. And just like Leah said, when I would say it, it would slip out of my mouth and then I would restate it. So so let's say I would say, so Tamara, you've been clean for 30 days, which I'm thinking that you have not had a single bit of methamphetamine in 30 days.
Mhm.
So just so
Or
they hear
use episodes, or
fewer episodes, right? And using the word symptoms, I think, I think is just a great word,
Mhm.
So, you're telling me you've been symptomatic. Tell me about that.
Mhm.
So I would say try it. And here's, I think, the biggest test, and Tamara, you can tell me if I'm wrong, but when you start doing this, you feel, I don't know, more pure. You feel better about yourself when
Mhm.
you use the medical terms as opposed to the name calling, stigmatizing.
Mhm. It feels, not to use a word that we don't want to use, but it does feel cleaner.
Yeah.
And it feels a little more professional, and giving regard to the patient, really that really accentuate patient-centered care.
Yeah.
So it's about 8 till. Should we show our second video? It's about
Yes.
2 minutes.
Let's do it.
Okay, here we go.
Hello, and thank you again for joining us here at SoCal Addiction Treatment. We've been doing a video series on all kinds of different topics within drug addiction treatment and different types of drugs. And the topic that we're talking about today is this concept of drug addict. we hear it a lot in the media, we hear it a lot in social circles, but this idea of a drug addict carries an incredible shaming stigma. And I think most people, including people that are struggling with addiction, and that's the term that I like to use instead of drug addict, is a person struggling with addiction because it's a disease. And so I like to frame it as, I don't identify myself if I have cancer. I don't say, hi, I am cancer. I don't introduce myself as, hi, I'm a person that is surviving cancer. I identify myself as Josh Beauchene. And so just like that, I don't like to identify someone struggling with the disease of addiction as a drug addict. I prefer to really identify them as a person who is a person struggling with addiction. And when people come into detoxification, which here at SoCal Addiction Treatment, we specialize in both triaging a person and getting them the help they need and tailor-making a program that works for them. And we also specialize in detoxification. We do the detoxification process ourselves here at our own facility. And one of the predominant features that we see with people coming in struggling with drug addiction is that they feel ashamed for being labeled a drug addict. And we have to help contain that shame, because shame is a driving force in addiction. And so when we use this label of drug addict, it tends to elicit that shame, and we have to really try to move away from that statement. You know, these videos are so short, and if I can say anything to you, I would say don't go at this problem alone. Get
That's great.
Okay.
So, and Angela, I read your chat. Yes, MS is one of the ones where they do use relapsing. When I was working in clinic, and
Let
I
us
was
help you get the healing that you need.
oh.
Sorry.
And I was learning about this. I was talking to the nurse practitioner that I was working with, and I said, are there any other? And she did mention MS, and that they use the word relapsing in there. So thank you. All right, so here is just a nice little handout, and I think we've talked about it, but what I like about this one is that it's, so if you are in an NA meeting and you're using the word addict, or you're in an AA meeting and you're using the word alcoholic, that's fine. But in public, let's don't. With clients, let's don't. Our patients, in our medical settings, no. Journalists really need to be educated. Substance abuser, nowhere. Okay, opioid addict, in your NA meeting, in your AA meeting, same as with relapse. Medication assisted treatment, we are now using medication for addiction treatment. And then the others are person-centered. So yeah, I think this is how you can get in touch with us.
Mm-hmm. Yep,
Any other
here's our-
questions from the group? We got like 2 minutes.
Welcome, and anything, any questions, thoughts?
So everybody will get a copy of the recording, and feel free to go ahead and share that with some of your coworkers as well. I would also really encourage you to maybe have a conversation within your organization about what are some steps that you can do to promote this. Can you have department meetings perhaps where you talk about this with your coworkers? Is this something that you could take to your leadership and think about how you could have an annual training? I think it's super important, because we know that people get help by being hurt, and whether that's the prison system or it's the healthcare system, we're the two social service organizations that end up being where these people land, and having a caring and compassionate person that's meeting the person where they are and having those conversations is super important.
Mm-hmm.
Yes, thank you.
Do feel free to contact Gina or I at any time with questions, and thank you so much for coming today and your attendance.
So please look at Leanna. I think that that's super interesting too. Is there something specific? You would love more training?
addictions or diseases like, Liana, are you thinking about like mental health or cancer or? Oh, she may have taken off.
So
Yeah.
like, I would just like to say like diabetes, oh
Mhm.
my goodness. And they are doing a lot of work with that too, and not calling
Yeah,
it diabetics. Mhm.
I know we're out of time, but I was Googling as we were talking, Stop the Stigma campaign, because I know I've seen that before, and I'll put that in our little blurb that's going to go out to all the people that registered. But on the CDC website, they now have a Stop the Stigma on patients with COVID.
Ah,
They
good.
do.
Yes.
Oh,
Yeah.
that is
Yeah.
interesting.
Yeah.
Okay. Good to know.
So
Uh,
shatterproof, interesting. I'll look at that.
All right.
Wow.
Thanks so
nice.
much, you guys.
Okay, thank you much.
Have a great holiday season.
Thank you.
You too. Bye-bye.
Bye.